Hi, everyone. Welcome back to our channel. For those new here, hi, I'm Dr. Jenny Lay. I'm a family medicine physician and a mom of two. So welcome back to Medical Mondays. This is where we talk about anything medically or non-medically related. Over the last 2 weeks, I've been talking to you guys about what to do during interviews, some of the questions you should ask during residency interviews, what subspecialty you should pick. And so today I just thought I'd talk about my own medical subspecialty, like I'm family medicine, and why it is such an amazing specialty. What are some of the scopes of practice? What can you specialize in? And what I do really on a day-to-day basis. So as you know, I work in family medicine part-time. I'm in an outpatient clinic. And then the rest of the time I'm here on YouTube, interacting with you all and just talking to you all. And so what I personally love about my practice is that I get to do whatever I want to do. So basically, I love procedures. Some of the procedures I do is just a lot of gyne procedures. So I do all the pap smears and I do colposcopies. And that is when you have an abnormal pap smear and you need to evaluate further, take a biopsy of the cervix. That's something I would do in my clinic. I do IUDs and Nexpanons. There's always training for things like this. So I know that some people are worried that, oh, if you don't get the training in med school, if you don't get the training in residency, where can you go next? There's continued medical education that we do as an attending. So you can choose to take those classes. Yay! Hi, John Ross. You made it this time. So lots of gyne procedures that you can do in the outpatient setting. And the gyne people in OB also were just like, FM, you should really do this because they are surgeons. The OB-GYN want to do like surgery, minimally invasive surgery. And they don't want to have their whole clinic just be pap smears. But I really enjoy doing those things. And so, yeah, send them all my way. I think it's so important that we all work together. And then a lot of derm procedures that I do lots of biopsies. So I do the punch biopsies, lots of shave biopsies, and then occasionally I'll do an excisional biopsy. And what that is that you actually cut out like a piece of a person's skin like this to take out the lesion, and then you bring it back together like that, and then the whole piece is out. So this is when I did that in residency. We did a shave, and then we found out that it was a specific type of cancer. So I went back and then I put like 3 millimeter margins on both sides. And the way you do that is like this has to be longer from the tip to the end point so that they will come together neatly. So if you have like even a really small lesion, the area that you cut out itself is actually pretty big. And what's cool about these procedures is that you have to do subcuticulars, which means you sew on the inside to bring the skin together so there's not so much tension. And then you do superficial stitches, such as like a running stitch or just simple interrupted sutures to keep them together. The key in having the skin not tension and pucker and scar is to do those subcuticular stitches. Yes. And then what other things do I do? I think it's really important that as family medicine, you know your restrictions, like you know the things that you don't know, right? I think that that's the most dangerous, where you're practicing medicine and you don't know what your limits are and you don't know what you don't know, because then you're not looking for those crazy things and you don't know when to ask for the specialist help. It can end up being very dangerous. So luckily, if it's any sort of melanoma like skin cancer, I obviously refer to the dermatologist. But other small things, or if the patient wants lasers, then I refer to the dermatologist. But when they can't get in and they want something to be biopsied right away, I definitely can do that for them. Other things that I do, I trained with an orthopedic surgeon up in my residency, and he also worked for like sports team. He had a fellowship in sports medicine, worked with the Lakers and all that stuff. So he taught me how to do joint injections, specifically the knee, the hip, and the knee, the shoulder, and the hip. So under ultrasound. So every time I was in clinic with him, and I spent like 4 to 6 weeks with him. So all the procedures he did, basically I would do them. He would just say that I'm the injection specialist. He would give me all the stuff, and then he would just leave the room, and then I would do it. So I got lots and lots of practice for that. What else did I do? I do regularly. I think those are the main things that I do. Oh, musculoskeletal. So I do a lot of OMT. So that is a type of manipulation specifically for people with pain. And it's also charged as a procedure. So some might not think it as that, but I think it's very important that you understand how to teach stretches and then doing the manipulation as well, because you may be able to help fix pain now, but when they go home and they are in their inactive lifestyle, the pain will return. So you need to think of preventative measures and give them tools in order to prevent that pain from occurring again. So sometimes when like people will be injured on the job, or they're in a car accident, or something goes into spasm like their muscle, I would inject them with a steroid. You don't have to inject with a steroid. The studies have shown that you can do dry needling, which is just a needle, or inject with lidocaine, or inject with a steroid, and all the results is the same. It shows that the muscle ends up becoming relaxed. And so I offer them that when they have so much spasming in their shoulders and they don't want to take medications, or they're a little bit older and a muscle relaxant isn't really good for them. Let's see. Let's do some. If you guys have questions, just leave it in the sidebar, and then I will answer them or pull them up to this box and then answer them. So any advice on choosing the order of clinical clerkships in third year? Yes, this is actually really important and such a great question. So it depends on what subspecialty you want to go into. So if you know that you want to, say, go into like OB-GYN, or you wanted to go into a surgical subspecialty, or even emergency medicine or something like that, I recommend doing it earlier on in the year, because you have to apply for audition rotations. And so you want to experience that rotation first to see, one, if you actually like the subject matter, if you can imagine yourself being in that subspecialty. And then secondly, it would be good practice for you so that you can familiarize yourself with what goes on in, say, like OB-GYN, how to deliver babies, how to write the note, some of the skills you need to work on, like the single hand ties, the double hand ties. And so knowing that will set you up for like the PIMP questions that you will have on the audition rotations. So if you, especially surgery, like if you wanted to do surgery, you really need to do it before Christmas, I would say, because people start applying for audition rotations for their fourth year super early on. I think that's what I remembered when I was doing my rotations. I had my OB rotation first, and I honestly really thought I wanted to do OB, and then I hated it, the rotation, possibly just because my preceptor was not good. And then I had emergency medicine, and then after that I had surgery. And so I fell in love with surgery, and then I realized that I only had a week or something like that to apply for some of the audition rotations for surgery. And so knowing that earlier on that you wanted to do surgery is better for you. So I would say put all the ones that you think that you'd be interested in first, so that you can figure it out and say that, yes, this is what I want to do, or no, this is absolutely not what I want to do. So yeah, that's what I did first. And then I did family medicine after I did my surgery rotation. So yeah, I hope that answered your question. This is a really good question. Okay, so it says, I know this isn't OB-GYN related, but I'm currently pursuing a bachelor's in psychology to get into medical school, hopefully. Have you heard of the Chicago School of Professional Psychology? No, I haven't heard of that school, but I think that, psychology is an awesome major to, like just to major in general. I think it can be very beneficial both for medical school and in real life. I don't I don't think that it's a bad plan at all if that's what you're truly interested in. Like I wish I had more experience in like psychology and psychiatry and all that things, but then it was really put on the back burner when I was in medical school. Like during medical school, I had 2 weeks of um, psych, and then I had like a rotation, like a 2 week rotation in psych. No, 4 weeks. Yeah, so it's like really, really, really short. And so you don't have enough time when there is so much mental health that is incorporated into medicine itself, especially in family medicine. So I feel like I took extra rotations when I was in residency, but there could never be enough. And so I'm listening to lots of books and trying to educate myself. But I think that if I studied more like you are doing in undergrad, it would have helped me significantly in my career. So keep doing what you enjoy. I think that will help in the future. Let's see what else. Okay, so back to what I was saying about procedures in FM. Um, you can definitely in family medicine, you can have different tracks. So you can do rural medicine, which means that you will be delivering a lot of babies. So when I was on my OB rotation, I was working with the OB gynecologist, but there was also a family medicine physician who was delivering his own babies and doing his own C-section. And he was the one who told me that he did a fellowship, 1-year fellowship in high risk OB. And then when I was in residency, there was another family medicine physician who did a high risk OB fellowship and ended up just doing gyne procedures for the rest of his career. So that's totally possible. The caveat to that is that I don't want to say you have to be, but I think it's more common in rural areas. My residency was approximately 1 hour from a major city. So like Seattle is a pretty big city, right? So like my residency was about an hour from Seattle. So not that far off. And you can still significantly expand your scope of practice if you are willing to travel or live a little bit further out. I think that, so there's different tracks, right? So you can go that route. You can also do like internal medicine. Like there are family medicine hospitalists where you work in the hospital. Lots of different procedures you can do in the hospital. That is a lot different than the outpatient setting because you need to be inpatient to do them. Basically like paracentesis or like at least in the ED setting. I would do a lot of paras, like most commonly in people who had cirrhotic livers due to prolonged alcohol use, and then their abdomen would fill with fluid, and then you drain that fluid called paracentesis. Or you have fluid in the lungs, could be from multiple things like either blood or infection, and we also use an ultrasound to draw up that blood. So this is a really good question. Can FM work in the ER? Yes, 100%. 50% of the doctors in the ED in my residency were FM trained, and then the other half were EM trained. So yes, you definitely can work in the ER setting. You can also work in the urgent care setting, and you do a lot less stuff there, but still like the classic things that you would do there is like INDs, I don't know what else you would do. Possibly injections, but I've done a lot of INDs or incision and drainage of like abscesses when I was in urgent care. So you can do the inpatient setting where you work as a hospitalist. And the culture of that is really, really different than outpatient setting because in the inpatient setting, it feels like a community of like people and doctors like all working together to take care of this patient. And it's really amazing. And it feels really good to be a part of something that large. So you as the primary hospitalist will be working with like cardiology and ortho and the surgeons and the lab techs and the nurses and just everyone to take care, like you'll be the main person for this patient. And then when you are off, which means that you can work 7 days, you can work 3 days, and then you would take an extended time off. Most hospitalists would work 7 days on and 7 days off. So when you're on, and when you're off, you're off. The different part in outpatient is that you have your own group of like a patient panel, which means that you would get to know your patients a lot better because you are seeing them through their lifetime and not just like a 7-day period at a time. So through the greatest transitions of their life, like the major events in their life, you are there and you are guiding them through those obstacles. And so it is very like, it's very heartwarming and gratifying to be in those moments. The downside of being on the outpatient side is that there's a lot of paperwork and there's a lot of behind the scenes that a family medicine physician does that doesn't actually get paid for. So you know how a lawyer would get paid if you send them an email and they have to email you back, or like the extra work or any paperwork that they have to do for you, you get charged for it. Well, as a doctor, I don't get paid for ordering labs and reviewing those labs with you. I don't get paid for reviewing imaging studies that I would get back. I don't get paid for calling you about your labs when they come back. And I don't get paid about sending you your messages. So say like a patient, I get this all the time. Like a patient comes in and they see me and then they will message me later and be like, oh, hey, I forgot to ask you about this so-and-so. And it's not like a simple question. It's complicated and we need thorough workup. And it's like, I would have to send them a whole paragraph message to convey a message. So it'd be like emails back and forth, but they don't want to come in because they don't want to pay another copay. And so it's really hard on the other side of it. Like you need to set boundaries because without those boundaries, I feel like doctors would just be kind of just burnt out. So lots of paperwork that you have to deal on the outpatient side doesn't ever really end. And so the perks on being on the inpatient is that you order labs, it comes back right away. You order imaging studies, it comes back right away. And then you review them. And once you are out of the hospital, you go home for the week, you don't have to touch any of that stuff. Like the next doctor who takes over the patients for you will be taking care of those patients. Okay. Okay, so here is the question. I am in family medicine, so we talk a lot about preventative medicine, and a lot of people have questions about the vaccine. And so this is a question from Bree. Can you go over some stuff that people aren't talking about with the vaccine? I have been hearing blood clots and people have been passing away only a week after getting the vaccine. So multiple statements in this. Number one, I've been hearing that there are blood clots with people who are getting the vaccine. So there have been blood clots that they have found specifically with Johnson & Johnson, but it's a very specific type of blood clot, not just a normal type of blood clot with people who have underlying blood disorder. And it is still extremely rare. I think they counted 3 people who had 3 or 6, I don't remember, but it's extremely, extremely rare for all the amount of vaccines that we have given so far. The chances of you getting a blood clot is less than you getting a blood clot on birth control. And then you getting a blood clot on birth control is less than getting hit by lightning. So you have to stratify the risks. Like, yes, there's a risk, but the risk is very, very low. right? So a lot of people take hormone birth control, which we know is like really, really safe because the benefits of it far outweigh the risks. And we know that taking birth control does increase your risk of blood clots, and vaccines itself has less of a risk than that. Some risk, but even less. And I have not seen any studies or any data that says that people who get the vaccine have died or passed away a week later. There's VAERS where people would like report adverse events, but does not mean they are correlated. Or causation and correlation. It's like, so the story that I would tell is that, say a mom comes in and it's the day where her 4-month-old is required to get vaccines. And then mom goes home that night, calls into the office and says that baby broke out in a rash. Is it due to the vaccine? And the doctor says, no, it's not due to the vaccine because the mom went home early and didn't get the vaccines. So just because it's on the same day doesn't mean that it is caused by the vaccine. Doesn't make sense? Like, just because something happened doesn't mean that it's because of that. So I still tell all my patients, like, we have given millions and millions of doses. If something bad has happened or if people are dying, then we should see that already. And so you always have to weigh the risk of everything you do. There's risk in taking Tylenol. There's a risk in driving every day. And what are the side effects and what's the alternative, right? So it's vaccine versus COVID. So we know that vaccine side effects include possible headache, muscle aches, joint aches, and feeling tired, lasting at most 72 hours. As compared to COVID, we know that you can have nothing. It can be just like a cold, or you can have prolonged headaches, autoimmune disorders, difficulty breathing, lung scarring, death. And so I think you have to weigh the risk of both and decide which one is better for you and your family. Yes, thank you, John Ross, he's much smarter than I am, but correlation does not necessarily equal causation. That's what I was trying to say. Thank you. Okay, this is a great question. Why do you think people, oh wait. Okay, so we'll do this one. Why do you think people who are pro-vaccine and anti-therapeutics and people who are pro-therapeutics and anti-vaccine, why can't we have both? We should want every weapon possible at our disposal. Yes, I also very agree. I think that both is great. I personally do not want to get COVID like at all in general, but I do think that we should still have therapeutics. And in research right now, I think we're researching both. We just haven't found therapeutics that have been gravely successful yet. So there's the monoclonal antibody, and then I think there was another one where it's a pill where you can take that also helps with hospitalizations. So we're doing them all at the same time. It's just that the medications have been taking a little bit longer for that data to occur, but I think it's important that we do have both. And so I have patients come to me who don't want the vaccine, and I talk to them about the whole risk and benefits and all that stuff. And I tell them ultimately it's their choice and they should decide. And they ask me, like, they're like, so even if I don't get the vaccine, will you still treat me? I was like, yes, of course. Of course. Like, that is my job as a doctor. I will still treat you no matter what your personal choices are, no matter what decisions you've made, no matter your religion, your race, like, it doesn't matter. Like, I will treat you no matter what. So if you end up being sick and you end up needing medication, whether or not you have the vaccine, we will treat you. So I hope that everybody understands that. What I do as a family medicine doctor, though, is we try to avoid disease and try to adjust lifestyle to avoid disease before that happens. And so, yes, I would treat you with medication if it came to that point, but my job is to educate you before we have to get there. Oh my gosh, this is I there is so much fake news that is being spread. I got asked if I felt guilty for allowing my child to have the vitamin K shot at birth. I'm sorry that you had to go through this. The vitamin K shot at birth is very, very important because vitamin K helps with like clotting so the baby doesn't bleed out. And I've had patients who delivered and their baby died due to like bleeding in the brain because birth in itself is very traumatic. Imagine the baby's head being squished and going through a birth canal, right? It's very, very traumatic for the baby as well. And a lot of the times they can have blood vessels break in the brain and stuff. And if it doesn't stop bleeding, the baby doesn't have that much reserve. Like they're very, very small. And so you did the right thing for getting the vitamin K shot. And so please tell these people to look at accurate resources and listen to reliable resources and not just anybody. Okay. Let's see. Oh my gosh, thank you. Heart. I love you guys. Thank you all for being here, by the way. It makes me so happy. Okay. This is a really good one. Can you speak a little on good financial choices to make in medical school and residency to minimize debt? I got you. Okay. I just realized I had a heart attack like on Friday because I was with a med student. We have like rotating med students from UW. And this med student said that her tuition was $65,000 a year. Can you believe that? $65,000 a year for for second year of medical school. First year is a little bit less because you get summer off. But the rest of them are a lot more. And I'm just like, that is insane. Like no wonder nobody wants to go into family medicine because you want to be all in high paying subspecialties to pay off this crazy amount of school loans. So what do you do because of that? I personally took out school loans to live. You do not need a cosigner. My parents were divorced. My mom did not make much money at all. And so I supported myself since like high school. And then when I went to college, I got a lot of like scholarships and grants and things like that. And so by the end of college, I want to say I had like $20,000 in school loans left. And then I went straight into residency. And my tuition was about, I want to say like $48,000 to $50,000 a year for residency. There are always scholarships that you can still apply for as a resident. I think you just have to write some essays, but definitely look into those. There are easier classes, not classes, but easier jobs that you can take, like not a crazy job, like don't work as a nurse and go to med school because you're investing in your future career. You should be studying as if it was a full-time job. And so I would say like if you can do something on the side, like do a teaching assistant or work in the library so you can study at the same time. Those are great jobs that you can take in residency so that you don't have to take up or take out that many school loans. You can be active on social media. Social media does pay you a certain amount, but you do have to be active on there. I feel like I started before the whole crazy boom in YouTube, But right now, TikTok, I heard they were paying a lot of money for medical content. And I feel that if you were studying and teaching people about medicine, you're killing two birds with one stone. So look into that. Some people started their own companies or things like that. I don't know. Like, you can definitely start a side hustle or a blog if that is something that you're into. I tried to meal prep. So I would cook all my meals. And I think living with someone can be a good or bad because med school, I said is really, really tough. And there's lots of different personalities in med school. But if you can find the right people who you jive with, I think that it's better to be in a group because med school can be very lonely and separating because you feel like you have to study so much. But being around other people, being able to study with other people to feed off their energy can refill that cup for you. And so sharing a house, like even a small house with somebody, can save you a lot on rent. What else? There's really, if you know that you want to go directly into family medicine or primary care, there are some residencies that can shorten the period for you. Like you go through it in 3 years instead of 4 years. But I would advise you that my only 2 cents to this is that to be a good doctor, you need life experience. So it's really hard to connect with your patients when you don't understand what they've been through or you can't empathize with what they've been through. And so a lot of the older patients look at me and they like behind a mask and goggles and they just see like a really young person. And so a lot of the times they're very skeptical when first talking to me. Because they're like, there's no way this person could understand. And then when I was in med school and I was on my peds rotation, all the parents looked at me like, yeah, this person can really, really not understand where I'm coming from, especially with all these children. And so it was only after I became a mom and after I became a parent that I was able to give like better advice and be more understanding to parents. And so, but yes, don't worry too much about paying your loans back while in medical school and in residency because there's the income-based loan repayment program. And basically during residency, I paid $0. I was part of the it's like repayee, which the government subsidizes 50% of all the interest that is unpaid. So financially and logically, it was better to save that money in a lump sum on the side and let it grow in, say, like a high interest rate savings account. I know SoFi has some of them. You put your money there, and then at the end of it all, like say after residency, when you make the big bucks, then you pay that huge lump sum back. I'll link that video where I talked about, or I have a playlist talking about med school loans and how to pay it back. But in that way, you're able to both save money and possibly invest that money and have it grow more than your interest rate and then pay it off at the end. Does that make sense? I hope that makes sense. For us personally, Stan and I paid $0 into our into the loan, my school loans. We saved that money. We actually invested in 2 homes, and I think we just got really lucky during this whole boom in the market. And so technically, if we sold both our homes now, we would have enough money to pay off my $350,000 school loan debt, or maybe just barely pay it off. Technically, we can do that, but then we'd be homeless with 2 children. So I think we're going to wait on that because I have until end of May to figure out if I'm going to refinance my loans or if I'm just going to continue on the income-based loan repayment program for another year. Okay. Let's see. How do you feel about stimulant abuse in medical school? Have you witnessed any in medical school and residency? I'm assuming you're meaning like Ritalin and Adderall. I don't know. So I have seen this when I was in college for sure. And I think some of the people that I knew in medical school also used stimulants to study, because a lot of people are gunners, as in like they want to score the best and they want to be ahead of the class, and that's how you get into top surgical or non-surgical residencies if you get the best scores. I would say that it's like, try not to focus too much on other people, just do you, and know that it's not about how hard you study, but it's studying in a smart way. So you don't need to study for hours at a time. You don't need to study every single waking moment and basically give up the rest of your life. I think that there are smarter ways to study in medical school and in residency and in pre-med in general. It's not about like passive reading or just listening to lectures, but actually about recall and learning how to take exams. So once you conquer those and once you're able to, learn how to draw that information out from your brain, it's going to benefit you in retaining the information. And so some people might need a stimulant, but unless you've been diagnosed by a doctor, preferably when you're younger, say like when you're 4 or 5, with ADD or ADHD, then, try not to be dependent on those things. Drink more coffee. I don't know. But I try not to judge people who do take it, because like I don't know them and I don't know their past. I don't know their medical history. So some people do really do need it. And I feel like we'd just be judging if we'd say like, oh, like, why don't you just study on your own when they really can't? It's kind of like saying, some people with obesity need medication to help them lose weight because they chemically in their brains, like they just don't have a full state, like they're never full. And so just to say, oh, like just eat less, it's like it's really hard to do for some people. And so I feel like we would be neglecting a big part of that. But there is a right way and there is a wrong way to be studying for med school. And if you haven't listened to some of Ali's videos, he talks about how to study in med school. I think those are really good. I can link some of those in the description box as well. Okay. Let's see. Sorry, I'm just reading through the questions. You guys have a lot. Oh my goodness. Sorry, guys. Okay. This is a good question. Do you have any thoughts on depression in the medical community? I think that, so there has been plenty of surveys and data that show that people in medicine have more depression than those in other fields. I think they also rank subspecialties on depression scale. Let me see if I can find this. Let's see. Okay. Okay, let's see. Depression rated by subspecialty. Medscape, depression, burnout. Oh, I don't want to put in this. I saw a really good one. Oh, here. This is the one I was thinking about. Oh, it's so small. Oh, dang it. It's on Medscape again. Let's see. Can you see this when I click on another page? No, you can't. Okay, here. So in this picture, this is from dates 2011, 2014, and then 2017. This bottom is reported burnout. And then on the side here is the subspecialty. So right here, oh, that's still a lot. Dang. So let's see. Where is the most burnt out? Oh, emergency medicine doctors. So sad. In 2017, this is like the last row. So burnout was a little bit better. OB-GYN a little bit after that. Family medicine about the same. Neurology, and this is, oh man, this is about over 50% of people in these professions report burnout. Oh, dermatology? Holy shoot. Where is this from? This is from the Mayo Clinic. Sorry, I'm just very surprised. I knew that burnout was, very high. Hey, it says dermatology here, but also dermatology here. Huh, interesting. What's this over here? Oh, percent satisfied with work-life. What's WIT? I want to say it's satisfied with their job. So dermatology has good satisfaction. So the best one I would say is preventative medicine, occupational medicine, and you get the most reward out of that. Pediatrics, you get paid the least probably. But pediatric subspecialties, you're fairly happy. Urology is least satisfied? Huh. Interesting. Whoa, this is like super interesting to look at. Well, yes, there's a very high burnout rate in the medical field, just because we in medicine, we don't have full control unless we're in private practice. Sorry, let's move this. The sun is moving. We don't have full control unless we're in private practice. So one of my friends, my close friends, she's working full time. So instead of working, basically it's very different for family medicine. So family medicine, when you're considered full time, which means you're working 36 patient hours, 34 to 36. That means that you are seeing patients for 36 hours of the day. And it doesn't count for the time where you have to write your notes. It does not count the time where you call the patients for abnormal labs or imaging studies. It doesn't count your on-call times. And so all of those things can be very stressful. And then when patients don't show up on time, and then you still have to see them, and then your day ends a lot later and you don't have that great work-life balance. So that control and that loss of control, and then feeling that you are stuck under this monstrous amount of debt, can lead to burnout. And then the thing about institutions is that they don't care about their doctors. Like the hospitals don't really care about, it's hard to say this, but like most institutions care about a bottom line, right? How much money they make. And so the greater that their margins could be is the better for them. And so when they say like physician burnout, like what do you try to do to prevent physician burnout? We make them do more modules to learn about physician burnout. We make them go to gatherings to prevent physician burnout. When actuality, we need to working less, we need to be paid more, and we just want to be compensated fairly for our jobs, right? And a lot of the times, like we feel like that is not the case. So yeah, I think that there has been so much, especially going on since COVID, like there has been so much expectation from us. And I feel like as doctors, we we do so much to just like give ourselves to everybody and to everything that it's very easy for corporations to take advantage of that selflessness. So yeah, I don't know how to change it. There's like a physician suicide awareness, but still, it's kind of like, oh, we should be responsible for an institutional thing that is messed up, right? We should try to change the rules. We should try to change these institutional things that are wrong. But like, I don't want to just say like, oh, you should just do yoga and meditate a few times to avoid burnout, when that's not the case. We need to change the rules. We need to have paid maternity leave or parental leave. We need to have adequate vacation days, good coverage, and enough time to talk to our patients. Like that's what we need in medicine. And so, yeah, continue to fight for that, both in like undergrad, in your residency, in med school, so that we don't have to deal with it in the future. But that's a lot of where I think burnout and depression comes from, at least from what I've seen. Okay. Yes, so great comment. General practitioners also are suffering from burnout, and many are leaving the profession early. Yes, I have been seeing that because we're not getting paid enough, right? So a lot of the pay comes from procedures. Like I don't get paid for counseling my patients about like a proper nutrition or proper diet, or how to cook brown rice, or how to get more fiber into their diet to lower their LDL cholesterol, right? I would get paid more if I was talking to them about those things and giving them an injection into their knee. So the incentive for doctors is to do more and talk less, I feel like. And so as a family medicine physician, as primary care physicians, our job is preventative medicine. And so the majority of what we do is education and counseling. And so and even with pediatrics. And so I feel like a lot of the times, like what we're saying and what we're doing isn't very like appreciated, and it isn't compensated for, but we do it anyways because it's the right thing to do. It lowers morbidity and mortality. And so, yeah, I am in the Facebook group, like, white coat investors, and I see a lot of people who are just like, I'm done, I'm over it. Like I'm over medicine and I want to do something else. And it is so sad. Yeah. Especially when people who are like literally a few years out of residency, like one of my close friends, like I was talking to her the other day, and we have this company-wide meeting, and they were talking about burnout and how our inbox has gotten so crazy. Imagine email, except on steroids. So as a physician, I have about 1,000 patients on my panel so far as a part-time doctor. And imagine those thousands of people like emailing you or asking questions or asking for referrals or requesting meds, and all these things and notes from other providers. Imagine getting all those things into your inbox and you have to review them every single day and be on top of that stuff every single day. And so what we're talking about was managing this inbox that we don't get paid for, that is extra work that we have to do, is causing a lot of us burnout. And like no one has ever come up with a solution for anything like that. So we talked about like hiring another person just to cover the inbox, or hiring like an NP or something like that to cover the inbox, or at least when we're on vacation. And someone even said like, we are over the whole like yoga retreat to address burnout. So like we are beyond that. We need real change. And so it happens every day and we talk about it every day. It's just, I don't know if things change fast enough. Okay. Sorry, it's really dry here in the winter in Washington, and so I'm drinking water. What do doctors usually do once they leave the medical profession? So I saw some of the comments on these posts saying that they can just do counseling or be like an advisor or something like that, or go into administration and do something that is totally not medicine at all, like go into teaching or something like that. Um, but they get away from direct patient care. So they're not working basically one-on-one with patients anymore. They can do something in billing, or they can also do like reviewing of records or something like that. I'm not sure. I didn't really look into it. I just read the prompts that they say, like, oh, I'm 3 years out of residency and I'm just so burnt out. And then like my heart just hurts. Oh, this is a good question. Do you want your kids to be doctors? If you could rewind the hands of time, would you do the MD route again, or would you do a PA or NP? So I do not wish that my kids were doctors. One, because it is so expensive. And it's truly something that they have to enjoy. So I love being a doctor. I love connecting with my patients. Like it really, truly like brings me happiness every time I'm in clinic. And even if I'm tired, like every day is so different. Every interaction with people, and just like here on YouTube, like every day is so different. And that's what makes it so exciting for me, that I constantly get to learn new things, that I constantly get to grow and be a bigger and better person. And that just like, it's so thrilling to me. And so if I were to do it all again, like I still would choose, like I'm actually a DO, so I would choose that again because I do a lot of OMT. That's one of my passions, to treat people with my hands, to be able to take away pain, just that physical and contact touch in general. I don't think that I can go the PA or NP route just because like I have a lot of anxiety in not knowing stuff. Like I constantly have to ask questions, and I would never feel like I'm confident in my abilities to be like a PA. Like if I were a PA, I probably would go like do one subspecialty and not family medicine, because I feel like you have to know so much of everything to be in family medicine. As for PAs, like you just have to know one thing, and if it's too much, like you just refer over to the dermatologist, right? So like you're like, oh, this is my small scope of practice, this is all that I do. Or be like an orthopedic surgery PA, where all you do all day is like evaluate people in the clinic, do injections, and then be first assist in the surgery room and do my favorite thing, which is like sewing the skin together, or like putting screws into like the leg or the clavicle. And so I think that if I were to do that, my life would be a lot different. Like I would choose a totally different career. But at the end of the day, I think it all comes down to mindset, right? You can choose to be happy of where you are and make the most of your profession and continue to strive to be the best in the career that you are. Or you can choose to be like, oh man, so much regret. Like I could have been something else, right? But you're not. So you can focus on those things, or you can focus on the happier things. I think that even if I were a PA or NP, I would try to focus on the things that bring me joy and bring me happiness. And so I can find fulfillment in those career paths as well. But as of right now, like I am super thrilled and excited to be a family medicine physician. I don't think I would have it any other way. Even with the whole kids and everything, having children and residency and all that stuff. Let's see. Wow, this is amazing. So it says, my PCP answered my message on a Saturday that set me straight to finish answering my messages from my own patients. Oh my gosh. Some physicians have to work on Saturdays. Remind you, I work on some Saturdays, like as a new physician in my clinic, I work 6 Saturdays out of the year. And so, like, I will also look through my inbox and answer messages on a Saturday. Yesterday, I logged into my inbox, and so I was sending some of my patients messages about their lab results and all that stuff too. But I normally try to leave work at work and not take it home with me. So I finish all my patient charts and do all of the stuff while I'm at work. And then when I'm home, I'm like truly home. Okay. All right. Oh, I don't want to end on a bad note, but this is such a good question. Okay. So, what should be done about medical bullying, preceptors abusing medical students? This is not okay whatsoever. I know some people do this, especially in surgical subspecialties, because this is the only way that they were taught. But it is not okay. I think it should always be reported and documented, um, so that something can be done. Something may not be done, but at least that it's documented and recorded. And I would say try to transfer if you are not getting the best education out of it, right? A lot of preceptors in the past were just like, I worked 100 hours plus and there was no cap and blah, 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 all that stuff. But doesn't mean that they should put you through the same trauma that they've been through. It more shows that this physician or this attending doesn't really know how to teach in general, besides like scare tactics and pimping and all that stuff. So a good doctor and a good doctor would also be able to be a good teacher. And so I would say, after you report this person, if you can't switch to somebody else, I would definitely give them feedback on how they have mistreated you to prevent them from doing it again to the next person. A lot of the times, though, I would say that these doctors probably don't know that they're doing this on purpose. It's probably a subconscious thing. And it's just something that, is kind of like automatic to them because they don't know any different. So I would say, please, as you live your life, if you go through your medical training, understand that you also make a difference. Your experience and who you are as a person, you leave an imprint for the people following you. And so if you can create a better learning environment, please speak up and please do that. So specifically for our residency, like we didn't have any curriculum or anything like that for those, or like time leave and all that stuff, because I was the first person in our residency to become pregnant throughout residency, and then my co-resident as well. And so we created this whole curriculum and all that stuff for people to come afterwards so that they wouldn't have to struggle through the same things that we went through if they also wanted to expand their family. But bullying, not okay. No matter who you are, don't take it from the nurses, don't take it from the CNAs or anyone. Like, medicine is teamwork, and you are most valuable as anyone in your team. So just because you're a med student doesn't mean that you don't know your shit. You know the most up-to-date shit. So educate your preceptors, educate your residents, and learn together as a team. Okay. Okay, let's see. Last question before I go. I'm taking a year off after undergrad to reconsider medical school. I want to ask, were you ever devoted as pre-med during undergrad? Any advice would you give? So I was very lost when I started college, just because I went from a very strict and restrictive family who always told me that I was going to do something in medicine. Like, they didn't really let me experience what I wanted or enjoyed in life. They rather just told me what they hoped that I would be. And so during the first 2 years of college, I kind of just like picked a chemistry major. And so, because I was just like, I don't know what else I enjoy. I enjoy science, but I don't know what career I wanted to do. So I didn't know if I wanted to be a doctor or a pharmacist or something in medicine. I wasn't sure at all. And I joined a pre-medical fraternity called Phi Delta Epsilon. And a lot of the people in there were like pre-med. Ultimately, a lot of them went into become a doctor or nursing or dentistry, and a lot of people didn't. And so just hanging around with people, like-minded people who were also figuring it out themselves, really helped me figure myself out. If I were to go back, I would say I would want to have more opportunity to experience medicine to see if that is exactly what I wanted or not. Best ways, I've said this before, but I'll say it again, like the best ways to experience medicine is actually to be in the thick of it. So scribing is a really good way to experience medicine because you are working directly one-on-one with a doctor. And then you write their medical note, basically. So not only do you learn how to write your notes, but you also learn the critical thinking skills of what goes into seeing a patient. What are your differential diagnoses, understanding how to educate a patient, how to be a good communicator, and then all the things that you should order, the medical jargon, all of those things you pick up in that job. Or like volunteering at a hospital, or just finding other things that you enjoy. Because there's so many other things to being a doctor besides medicine. As I said, there's the communication skills that you need, there's the personal skills that you need, and it is your life experience. That is how you connect with your patients. And so don't think that that's just nothing, right? So, if you're interested in exercise, if you're interested in nutrition and diet, all those things are going to be really beneficial for you as a doctor. So I don't think that you should think any years off or any gap year is considered a waste, because it's the life experience that you will use later on in your career anyways. Medicine doesn't stop. You continue to learn even after residency into becoming attending and onward forever until you decide that you don't want to be in medicine anymore. But medicine is constantly changing and you will be constantly learning. So please don't think that just because you're taking a year off, it's being wasted. Just make sure that medicine is what you really want to do, so that you don't regret it later and you're happy in your life's choices. All right. Lots of questions today. Oh my gosh, I can't have time to answer all of them, but thank you guys all so much for watching. I appreciate you all being here. Let me know if you want me to talk about anything else specifically in like the comment section. I have been doing a lot more vlogs because you guys told me that you like vlogs. December is coming up, so we will possibly do Vlogmas as well. Just let me know what you want to see. As I said, I'm a mom. I'm a doctor and I work part-time. I do lots of procedures. And so I enjoy working out and weight loss and all that stuff. So, and mental health. So lots of things that I'm interested in. My brain, like I have ADHD, so my brain's like all over the place. So you guys help me center myself. All right. Thank you guys all for being here, and I'll see you guys again next time. Peace.